I would like to introduce Sharna Prasad. You have her bio, but just to say that she is a therapeutic pain specialist and has a mindfulness-based stress reduction teacher in training going. And she actually joined us from Oregon at a place called Lebanon Community Hospital. And she's going to be sharing her experience. Please help me welcome Sharna.
Thank you, Barbara. So June 28th, 6:50 in the morning, I had my cup of tea, chai, in my hand. So I'm from India. In India, we make our chai with black tea, sugar, milk, and freshly ground spices, cinnamon, nutmeg, and cloves. And I was enjoying my tea, and I got a message from my primary care, very close to her. She really cares, very caring physician. And this was the message. But before I go there, I had recently been diagnosed with a medical condition. And this is what she sent me on Facebook Messenger. How are you doing, dear? Is the medication agreeing with you? Does it work? I hope you're okay. I think of you often. Aw, thanks. That means a lot to me. The medication's working really well, which surprised me. Going on into my lifestyle, a healthy lifestyle, we'll see how I manage this. Well, I hope you don't get tachyphylaxis over time, dear. How many of you in this room know the meaning of that word tachyphylaxis? Please raise your hand, because I need to know how many physicians are in this room. The most inflammatory foods, it's hard. Well, I love you and would be devastated if you get debilities, dear. So, I'm a physical therapist. What do I deal with? I'm always afraid of working with people with debilities, right? And here I am facing it face on. So here I am in my catastrophic mode going, what is going to happen to me? Of course, I have no idea what that word means, right? So this is what happens to me. Tacky. I know that word, tacky. Tacky means tachycardia. And my heart rate was 150 beats or who knows how much. And then the next word was phylaxis. I can figure this out. I've been a therapist for 29 years, or how many ever years that adds up to being. It says phylaxis, as in an anaphylactic response. You have an anaphylactic response, you can die from it, yes? I am going to die from a tachyphylactic response is all I could put together. That was death for me. And I was very upset. I was supposed to go to work, but I had this acute episode of the heart beating crazy. So I said, it's time to say my goodbyes because I'm gonna be dead. I started texting my kids. I have 3 kids. I started texting them, just remember all the things I've told you in life, because then they don't listen to you anyway, right? So it was all about in the text, I'm giving my husband extra hugs. The dog's getting extra treats. Who cares if he's gonna be obese? Hey, I'm gonna be dead. I won't be there to see him anyway, right? I go to work. I can't talk about this because this was too much for me. So at lunch, I say, finally, I'm going to tell one of my coworkers. I share this text with her and say, what do you think of this? And she goes, Sharna, did you look it up? I said, why would I look it up? It's a scary word. It's a nocibic word, as in placebo, as in help, that can help you. And this was a nocibic word. I'm not doing that. All I do is read about pain. I know what it's all about. These doctors send out all these negative words and then you get all scared. So that's what it's, one of those negative words, and I'm not going to look it up. And she said, Sharna, this is what it means. You're not going to die. It just means that you're going to overall need more medication. I was like, oh, okay, I'm not going to die. So language and words and their meanings, right? It has so much to do with it. So what I'm going to do is, I love chaos. I love mosaics, and I love puzzles. So what I'm going to do is give you an outline of my presentation, and that is I'm going to share with you my chronic pain story, as in how I went through this, in how I transformed as a therapist and a patient. I'm going to give you my take on the epidemic, and then some of the programs in our community, some patient narratives, some simple ways of how you can turn this, how you can turn some of these experiences around. And then I have a research paper that I want to discuss with you on provider narrative. New York City, 1988, 89. I had just moved from India as a fresh physical therapist. I helped a patient stand up in the parallel bars, and she resisted, and I had some pain in my neck. Well, I was a fit PT. That little twinge didn't mean anything to me. But 2 years later, I had pain radiating into both my hands, with tingling and numbness both hands. I was scared. Well, why would I see a physical therapist? I was the physical therapist. Don't I know enough? Was I good enough to treat myself? No, I was not. So I lived in that space of, you're not good enough. Finally, I go and see an orthopedic surgeon, because that's what you do, right? You have the symptoms, and I saw an orthopedic surgeon. I did not feel the pain when I was at work, but I would feel it when I was walking home to the bus stop, and I would feel so helpless and so hopeless. I saw the doctor, the surgeon, and he got an MRI, and he said, Sharna, you have a C5-6 disc herniation. Your disc is like a jelly-filled donut. It's all squished out, and you don't have surgery. You're going to be paralyzed. And I said, I was scared, again, and he let me go home. So I went home, and I said, wait, if I was going to be paralyzed, why did he not send me to the OR? And if it was that serious. So I knew it was not that serious, and I started reading up the research, and what I found was the surgeries did not really have that much of, it wasn't that different over time. The pain was not any better. But I was worried nevertheless. So I started taking courses in pain, in movement. At that time, they didn't have that many pain courses. They had more movement-based courses. And I learned some new techniques. I was picked as one of the patients in a big course with 100 PTs. And they taught me how to move safely. 6 months later, I was pain-free. I learned that was the technique to use with all my patients. My patients started getting better. It was lovely because I had a personal experience. I had a new technique to use, and I treated all my patients for decades. And I knew I had a jelly-filled donut that was squished. Fast forward, I had kids, 3 teenage kids, severe low back pain. This time, I could not get my pain under control. None of the techniques I knew worked for me. I would get out of bed, crawl out to the gym, because I knew as a physical therapist I needed to move. I would work out, go to work. I didn't care if my patients got better or not. I was in burnout. And I went from a sitting chair to a standing desk because we were told in our profession sitting was the next smoking. Sitting is bad for you. By the way, that's bullshit. Excuse my French. And now I believe that my jelly-filled donuts this time in my back is fully squished out. Very frustrated. I didn't know what to do again. Well, we talked about that. So I met a crazy doctor. He is Dr. Kevin Cuccaro. He is an anesthesiologist, a pain physician, and he was introduced to me by our librarian, who said to me, Sharna, you guys keep asking for the same articles. Why don't you guys meet? I'm like, okay, let's see. So we start talking, and I said, so you're an interventionist, pain doctor, tell me more. And he says, well, I don't do interventions. I'm like, what's wrong with you? And he said, I said, what do you do? See, I teach residents and physicians about pain. I'm like, what is there to teach about pain? I just couldn't get it, what he was trying to say. And he said things like this: I'd rather be financially bankrupt than morally bankrupt. I know how much money pain doctors make. There's a lot of money in pain medicine. And I know that because I have family members who are multimillionaires and pain doctors. I do. So I was very confused with this man. And he gave me a podcast, which is really long, and I heard it over and over again because it was totally not making sense. The jelly-filled donut, and he was saying the attitudes and beliefs of a provider can affect the patient's pain. I said, that is pure, I'm gonna not use words because it's being recorded. So it was very confusing for me. So frustrated, I went to CSM, which is our combined section, the PT meeting. One thing else with Kevin was I did not listen to him properly because he was a doctor. He was not a PT. He was not my peer. Doctors don't know what we do. Doctors are doctors and PTs are PTs. There's this difference, right? We don't know what doctors do every single thing, but they don't know what we do. So there was that difference in language. So there was this a little bit of resistance. So I go to CSM. CSM, Adrian Lau, I finally ended up doing my training with him, and he is a PhD PT. Now I'm listening. Kevin and I spent 1 year meeting once a month, and he was trying to explain the science behind pain. I wasn't getting it. And mind you, I was the pain PT. I was a senior therapist in my clinic, but I was not understanding pain. So at Adrian Lau, the first question he asks is, what is pain? I'm like, that's a really dumb question. When you get hurt, you have pain, duh. And someone in the audience said, pain is about protection. I said, no, it's not. You don't know. I'm 29 years out of PT. You're just a fresh grad. You don't know what this is. And then Adrian validated it and started explaining pain is about protection, and he started talking more about it. And that's when I sat and said, wait a minute, how can pain be protection? It was jelly-filled donut for me. And I've reflected back. My New York experience with my neck, I looked at all the psychosocial factors around me. I was lonely. My telephone bills, mind you, we didn't have cell phones at that time. How many of you know that era, right? My telephone bills were $700 a month. And I reflected back, sitting at that conference and going, oh my gosh, there was so many other factors that were playing into my neck experience. I came back to my back experience because I had pain at that time. And I said, wait a minute, I've got all this stuff going on with my kids. I was raising Indian parents raising American kids. And there was a clash of values, clash of expectations. They wanted to be cheerleaders. Well, Indians don't do cheerleading. We do science clubs and robotics, right? Don't you know them? We don't do that kind of stuff. And they wanted to go into sororities and fraternities. We don't do that kind of stuff. You stay home. Don't wear those mini skirts and dance around. So I was having issues with my kids. And I didn't realize how those factors were affecting my pain. But once I started getting that whole picture, I go, oh my goodness, my back is just fine. It's those kids that are contributing to my pain experience. And my belief system came shattering down. It was a big shift, but I had no idea how to take this over into clinical practice because I struggled with it. But here was my jelly-filled donut dialogue, which worked really well for me for all these years. And now I had to change it to a biopsychosocial, and there was a lot of discomfort as a clinician. I could not do that. Okay, moving to the epidemic. Okay, this is my take. No research on this. This is just me talking, okay? Please don't. So we're calling it the opioid epidemic, right? Let's for a second put the opioid epidemic on a shelf, just for a second. And we call it a typhoid epidemic, right? We go into the typhoid. Salmonella, food, water, it's affected. The drug of choice is penicillin. For some reason, the pharmacy or the drug company messed it up, and the penicillin is killing people. Okay, that's what's happening now. So we are having problems with giving people penicillin. So what are we going to do at that time? Call it the penicillin epidemic? Do we change names at that time and call it the penicillin epidemic, or do we still call it the typhoid epidemic? What do you think? Typhoid epidemic? Because you're still going to have public health education with the community on how to eat their food, how to drink water. So the problem with this is we have labeled the epidemic wrong. That's my take. I'm ready for attack later on. But we have labeled the epidemic wrong. It is not an opioid epidemic, it's a pain epidemic. And the reason we are chasing our tails with opioids is because we're not addressing the problem, and the problem is pain. And this is the problem. Our society is in pain. What we have is biology is yay small. And this is where our whole healthcare system is focused on. Or the majority of it, sorry, not the whole, majority of it. Psychology is yay big, right? And that is your trauma and adversity and everything psychologists do. But what is the social pain? That is from here to Oregon. That is what is our problem. And the social determinants of health, bullying as a culture. As a healthcare culture, we have hospitals where we have bullying. We have school systems that have bullying, right? And then the last one is deaths of despair. Angus Deaton. How many of you have heard of him? Angus Deaton. Angus Deaton is a Nobel Prize economist from Princeton. And he has an interesting article on the mortality and morbidity of the 21st century. It's through the Brookings Institute. How non-Hispanic white men, their mortality is on a rise. This is scary as compared to the rest of the Western world. This is something to look at because we have poor health, poor mental health, social isolation for multiple reasons. Loneliness, obesity, marriage or lack thereof, poor labor market opportunities, and lack of education are some of the leading causes of this rise. This one is, same article, drug, alcohol, and suicide mortality in men, women between the ages of 50 and 54. This is something to be concerned about. This is societal pain. It's very big. This epidemic has hit us hard in Oregon, right? I don't know the stats in Washington, but in Oregon, we're the 6th highest percentage of teenagers with a substance abuse problem. We have 500 pregnancies were complicated last year from overdose. We have infants coming out with withdrawals. 57% of 12 to 17-year-olds who misused prescription of opioids got it from a friend or relative. We are 6th in the nation with this problem. We are 49th in the nation with resources. I love Oregon. I have chosen to live in Oregon to raise my kids. So we had to do something about it, right? Be the change you wish to see. So this is the change we brought on. We don't have the luxury of Swedish to have a multidisciplinary team because we're in rural Oregon. We can't even find an OT to join our team. for the last 2.5 years. We don't have a psychologist that is pain informed that can join our team. So what did we do? We created our own program. We took the research that is out there and we brought in a group program for our patients. So we evaluate them as a physical therapist. We have a very one-on-one conversation with them. They want to, we put them in this program. This program is 8 weeks, 2 times a week for 2 hours each. It's called MAPS because it's movement, mindfulness, and pain science. That's what we bring there. So it's fairly intense. We have a dropout rate because once the patients find out this is hard work, they do drop out. The attrition is high. But the ones who stay, we don't talk opioids that much. We only talk pain. So this is what's happening in this program. We have patients who are understanding their pain, and they're choosing, mind my word, they're choosing to get off their opioids. It's a choice. We have the data. We don't have enough resources to analyze the data. We have data from 2.5 years. What has happened is people from this group class have now formed their own group. It's a patient-led initiative, which is what we're very proud of. They call themselves Marble Jar, after Brené Brown's work. I don't know how many of you have heard Brené Brown. So they have their own group. They do movement, they do mindfulness, and they're carrying on their work. Self-directed, very empowering place to be. So this is what we found. With the small number of patients that we've got, we had 24% decrease in ER utilization. This was huge. Now we're waiting to see what the big numbers show us, but it's coming. So I told you I have 3 kids, teenagers. So I would go to the classrooms and present. I just made a presentation on the opioid epidemic, pain, and healthy self-care. 90-minute presentation. And the next thing, the teachers and the students started giving me feedback. I would give them a little slip of paper and say, what did you get from this talk? And they would give me feedback that we want to hear more. So I said, okay, well, I guess this is not bad. They want to hear more. So I applied for a grant. Next thing, I got a grant. Corvallis High School, freshman year, were changing their health curriculum. So they gave me a grant to create a curriculum for their health class. And that's what we did. So we took that 90-minute presentation, chopped it up into 4, expanded it, and we have a curriculum now. So we've created a website. It's called Selfcare Transforms Healthcare. We might change healthcare out. It's a little political, but it's there. So this is what we're doing now. So we do a 1-day training for the teachers, and we're inviting teachers from all over Oregon or Washington, or nobody from Washington's come there, but it's just new. It's a fairly new program. So we do a 1-day training. We have them. We give them a nice folder. We give them a USB. They've got the program. They can take it into the schools and start primary prevention, because that's what we need to catch this upstream, not because downstream is very expensive, right? We need the multidisciplinary teams and et cetera, et cetera. And we don't call it multidisciplinary teams anymore. We use the term, I heard that term, transdisciplinary team, because that's what we need. The PTs need to know what the OTs are doing. The OTs need to know what the psych is doing, as well as everyone in the team. And we love that. We have surgeons now who are starting to get this concept. So what they're doing is, we have a bariatric surgeon who, we talked about this, is like, why would you not walk your patient while you're talking to them? Why? So she does that. Every time our bariatric patients come for a assessment, she takes them for a walk. So there is that movement piece that gets moved around. Of course, we are just movement folks, so that's all we do, right? So this has been a big hit for us, and we're very proud of it. This is another one, Oregon Pain Science Alliance. So we came to Seattle to listen to Lorimer Moseley. Lorimer Moseley is a neuroscientist. He's got books and Explain Pain. Dr. Hanscom knows him well. He came to Seattle, and we attended his 3-day workshop. His big thing is No pain receptors. Don't use, anytime you hear the word pain receptors, you've got to go, ah. So we're going to try it? So anytime you hear the word pain receptors, pain pathways, pain center in the brain. So those are your 3 A's according to his presentation. Don't use that. So what we did was we got really excited. It was like, oh my gosh, there's neuroplasticity. Pain can change. Wow. So we went back to our clinic. Dr. Kokaro, Leanne Deich, social worker, and myself, we started doing once a month programs in our community where we would go and do a pain talk for free. You just show up, no registration, you show up. Sometimes we would have 3 people, sometimes we had 80 people. But that program for 3 years is now patient-led. The patients rose, and they are creating, they've done their bylaws. This is going to be a nonprofit, 501c. Who's leading it? The patients. We have retired attorneys, you know how you, so it's the floor is rising. So this has been great because now we are communicating with our peers in a very simple language. Because language has to be simple, otherwise we would, you can't use big words when we're talking to our patients. Or the health literacy is what grade? 5th grade is health literacy. So our language on pain with our patients or with our peers, peers, I guess you can talk whatever, but patients has to be 5th grade literacy. And this is our summit. So what did we do in this summit? Oregon Pain Summit, so this is going to be our 2nd year doing the summit. I would encourage you guys to come to that. So it's only about pain. We don't talk opioids. We only talk pain. So this summit, what we did was we went into our community of providers and we said, hey, you're a sleep doctor. Would you be willing to speak on sleep in our pain program? And they would say, sure. But it's like, I know nothing about pain. I said, oh, we can give you a little training on that, and would you be willing to? Oh, you're a dietitian. How about diet? Would you be willing to speak there? So what we did was we got our community experts to become pain wise, pain aware. So they started speaking the pain language. And that rose the community. Dr. Hanscom was one of our speakers as well, and it was great. So we're going to do it again. It's on January 24th, 25th. It's a two-day conference, and then we have a workshop. We have 4 workshops after that. So this was our highlight. Our elevator pitch to our community is all pain is pain. And the confusion that has been created is, and there is research to prove that. I don't have the research right now to explain the all pain is pain. It came out like 2 days ago, sorry. I had already sent my slides to Robin, but we've been saying this forever. All pain is pain. You don't need to differentiate acute, chronic, psychological, social pain. Just look at it as a general. All pain is pain. And the management is different, but pain is pain. The difference is, look at pleasure, right? Can you say, how do you describe pleasure? Think about it. We'll come back to it. So all pain is pain. All pain is real. Does not matter how much opioids our patients are on. If they come to you and say they're on pain, they are in pain. If they're saying 12 on 10, yes, they're not being heard. If they're saying they're 10 on 10, they have not been heard. And when you hear providers who are so frustrated, and nothing against providers, they are so frustrated with this situation. They say, I've heard this story 1,000,000 times. Well, if you've heard this story, have you validated that story with them? Because they don't feel like you've heard them. And that's where communication skills need to come in. But we know that all pain can change, right? In some form or the other. So this is my favorite part. So this is about a patient. We're going to call him John. John was 63 years old, not his age, but we're going to leave it at that. He comes to my clinic, and he's telling me his story. And I said, go ahead. See, we have the luxury. PTs and OTs, I don't know which clinic we get an hour with our patients. So we have this one-on-one time. You just take care of yourselves. You sit down and say, I'm ready for your story. And I shut my mouth after that. I don't speak. I just wait for the story to just unravel. And I found that way better than ticking off boxes, because what happens is when they're telling their story, they're going straight to the point that's bothering them the most, right? So John tells me, I've been having pain for the last 3 years. I retired 3 years ago. And it's severe in nature. I'm not able to do much of anything. And said, what do you enjoy doing? And he said, I like making picnic tables. I've been commissioned to make 3 picnic tables, but I have not been able to make them because I've been in so much pain. And I said, so what do you think is going on? He said, I have spinal stenosis. And I said, okay, and what are you afraid of? That's my favorite question to ask. What are you afraid of? Please add that to your questioning, because that you get so much out of it. And he said, I'm afraid of depending on my wife. I am afraid of making dumb financial decisions. And I'm afraid I'm never going to be able to make my picnic tables. And sometimes they'll say, what do you mean? What are you afraid of? I said, I just keep quiet. I just let them answer. Wherever they want to go, I'm afraid of spiders, I'm afraid of this. It doesn't matter where they go, but we let them go free range. So then I said, okay, what does spinal stenosis mean to you? And he said, it means narrowing of the spinal canal. I said, what else? He says, my nerves are getting pinched. And then he said, it's hereditary. My mom had spinal stenosis. I said, okay, and then what else? And he says, I'm going to be paralyzed and be lonely in a nursing home. And that's when he had an emotional response. And I try to wait for that emotional response to see what is it that is really, really bothering him. So I said, okay. I said, is it okay if I take a look at you? And he said, sure. So we're going to do the examination I do. I'm just going to do one thing. So move your chairs back, because we are PTs. We have to move. All right. So what I had him do was do a 30-second sit to stand. And that's going to look like, I'll do it with you, except I'll be out of breath soon. All right, so ready? So what you're going to do is you put your hands on your chest, and you're going to sit and stand for 30 seconds, all right? And at your pace, what works for you, what is safe for you. And I have them count how many they can do. Five more seconds. Okay, stop. How was that for you? How long did it take? How long did it take? Thank you, thank you. So I had him do that. I checked his mobility. I looked at his back. I had him get on the floor. I said, stand up. And I said, wow, you've got good strength. Look at you got on the floor. Look at your flexibility. You're doing really well. And then I talked to him. I said, wait, what's the function of nerves? I talked to him a little bit of, science. It's like, there's sensory and there's motor. Sensory is in, feeling, touch. Motor is the strength. But you don't have any of that. You don't have numbness. Your reflexes are good. The nerves are really not pinching yet. But you know what? We're sitting on an earthquake zone here. We might be having an earthquake anytime soon, so we can all just stop working and just wait for this to happen. Or we can go ahead and just keep doing what we want to do and live our lives, and when the earthquake comes, we'll figure it out, go to our neighbor's house and get some water, because they'll be better planned than us. So he said, okay, well, and then we went in a little bit into the pain science, and we saw this definition up there. So I like to use Dr. Kokaro's definition, how he explains it. So what he does is, he said, how is fire? What is fire made of? Right? I've already given you the answer, so it's over there. What happens if one of the elements is not there? Fire is gone. So he takes that same definition and puts it into a fire analogy. The reason that fire analogy works really well, it's a quick way of explaining pain to someone. And the other thing is, it takes the whole definition of pain into that analogy. Fire is an emergent process. That is something you may want to look up. I don't have time to get into that. It's an emergent process. It means it doesn't have a linear path. It's not like, I hurt my back, that's why I have pain. I hurt my back, and there's a gazillion things happening around it that is eventually causing my back pain, right? So that emergent process is very important to understand. So and the other thing about this definition I like to emphasize is the word experience. It is an experience, right? And this is why it's such an important part of the definition, because it's an experience. When you interact with your patient, you can change that experience. And that is the most empowering part of this. Okay, so I said, here is your triangle. These are the things you shared with me. And this is what you told me are your body sensations. And these are some of the emotions: loneliness, hopelessness, fear, frustration, right? So he got it. And then he came back to me the next time, and I see my patients once a week, and he came back with a frown on his face, and he sat down. I'm like, oh, God. And he said, Sharna, I have no pain. And I said, what? And he says, I have no pain. I said, tell me more. And he said, I went home, I talked to my wife about all these emotions and thoughts and sensations, and she was really happy because I never talk about emotions with her. So she said, oh, this is good. But that same evening, I had beer with my friends, and they said, what? She didn't work on your back? She didn't touch your back? No, don't go to this therapist. This is not the right thing for you to do. I said, and what did you think? He said, I thought I'll just give you a try and see what you had to say. I said, okay, good. So I said, and what did you do next? He said, next day his goal was to walk to his shop and to walk to the mailbox. That's how debilitated he was. So he said, I went to the shop, I dusted, I just looked around all my wood and my tools, I just touched it, came back. The next day I went back and I turned them on, and the third day I turned it on and I cut some wood. And then I started going. And you know what? I made 3 of my picnic tables, and I cut wood for 8 more, and now I put it on Craigslist, and I'm getting orders for that. And I said, wow, so you have no pain right now? He said, nope, I have no pain. I said, okay, well, talk relapse, Sharna, talk relapse, because this is coming around the corner. So we talked relapse, and I gave him all this. I said, come back in a month, because I want to see if you're doing as well, where he was a no-show. And so I called him, and I said, John, what's going on? We were supposed to check in. He said, don't worry about me. I'm loading sheetrock in my truck. Okay. So I love stories. So this was a retired vet. He had spinal surgery, a fusion, and he was coming in for physical therapy, and we were working on this equipment. And then he said, my back is barking at me. Oh, so he said, my back is barking at me. I said, oh, okay. And then we moved on to another equipment, and we keep working on. And then he said, and I said, so tell me about this dog in your life. And he just looked at me and said, my wife's damn chihuahua, that's all he does is bark at me, and all she cares about is this chihuahua, and she has no time for me, and he just took off on that. So my lesson here is listen to the metaphors, because words, a picture is 1,000 words, and a metaphor is 1,000 pictures. So the metaphors are very key. I got one more. So this is an older woman with neck pain. She comes to me, and she could not, her driving was very difficult, impaired. So she said, every time I turn, I get this clicking sound. I said, tell me more. She says, every time I click, I feel like my vertebrae are sliding over each other. And I'm like, oh my gosh. And what else? Says they're going to slide, and they're going to hit my spinal cord, and I'm going to be paralyzed. This is very important to wait for. It's 30 seconds more, but what is the meaning of their pain? what is the meaning of that clicking? So I said, are you okay if I give you another analogy? She said, sure. So when you open a door, it makes this squeaky sound. What does that door need? And she said, well, it needs some WD-40. I said, that's what our joints need. So there's synovial fluid between your joints. Every time you move it, the synovial fluid is increasing and it's lubricating that joint. So you don't have to go to the click, just stop before it clicks and you just increase the fluid. And she's like, oh, I can do that. Just don't go and buy WD-40 because I've had a patient who did that when I explained that. And he went and bought buy one, get one free and sprayed it on his knee. So I do make sure that you clarify that. So this is an interesting research paper that I read is Do Words Matter? Stigmatizing Language and Transmission of Bias in Medical Records. It's a proof of concept. It's a very recent article. And what they did was they took it was a 28-year patient with sickle cell disease. It's a made-up patient who comes to the ER. And they made 2 vignettes. Or I'm not saying that right? And they made 2 of them. One was with a stigmatizing language, and the other one was a neutral language. It was very subtle, and they gave it to 413 medical students and residents to see how bias is being transferred in medical records. And it was very subtle. So if you read it, it's very subtle. Still has 10 on 10 pain. Pain is still 10 on 10. Not tolerated his O2 mask, refuses his O2 mask, opioid, narcotic. He spent his afternoon with his friends. He was hanging out with friends outside McDonald's, emphasizing the lower socioeconomic status, right? Easily aroused and distressed, easily arousable and cussing at the nurse. And his girlfriend is by his side. His girlfriend's lying in bed with shoes on and requests a bus token. So the residents and the medical students who read it, they definitely had a stronger bias towards the stigmatizing language versus the other. But what this did was help me change my language. I would write a note and say, wait, let me make sure it's a neutral language, or did I add something in? But it brought in awareness to this thing. So provide a language. What I suggest to you is to keep the safety in your language more. You use a word like arthritis, you don't know what this patient understands. Arthritis may mean death, like tachyphylaxis. You don't know that. So the best thing you can do is teach back. What did you get from today's session? Take a few seconds to please ask that. What did you get from today's session? And whatever it may be, but they're not walking out of your office scared. That's what you don't want. Okay, please. So you have a disc bulge, arthritis. So instead of telling them what's wrong with them, tell them what's right with them. Right? My spinal stenosis patient, I forgot to tell you, what he said to me, I said, what changed for you? He said, Sharna, you said I was okay. That one sentence stuck with him, that you are okay. Right? So, and you don't know what's going to stick with them because you might be saying very positive things and something negative they pick up. So it's always good to check on the teach back. Weakness versus strength. You have weak, PTs are good with, you have weak core muscles, you have weak glutes, you have weak, everything we tell them. Instead of that, you say, you have really strong, your body's really strong. You got up from the floor. You're doing great. Focus on the glass full rather than empty. Drug seeker versus empathy seeker. None of our patients want drugs, right? We have that great cartoon of the leg being cut off and, you know, who's faking their pain? They're all in pain. We've just not addressed it. So they're empathy seekers. They need our empathy. They need listening. They need that warm hug, which they're missing. Drug abuser versus drug user. Should versus choose. I love that. You're going to tell me when I'm completely... That sounds great. I'm almost done. Should versus choose. I tell them, I say, take that word and throw it in the garbage, should. Because we give them exercises and they say, oh, I should do these exercises. I said, no, no, no. You choose to do these exercises. This is not mandatory for you. And they said, what do you mean? They've never heard that because all PTs say you should, right? I said, try it. I have dishes in the sink. I should do the dishes versus saying, I choose to leave the dishes in the sink. It's so empowering. Just try it out. It's so empowering. So when they get that, they go, well, I choose to not do this. Or they start saying things to their husband, saying, I choose to not, listen to your blah, 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 or whatever it may be. And then trying versus practicing, they use the word, I'm trying to do these exercises, I'm doing, and I say, you're not trying, you're practicing. You're already doing what you need to do. And if you forgot to do it or you didn't do it, you chose something else. And what can you do about this? You need to understand your pain first. You need to understand ACEs for yourself first. As a provider or as a participant in health, when you're dealing with people with so much trauma, you need to understand your own trauma first, right? You cannot pour out of an empty container, right? Our providers are burning out, and we can't let that happen. We got to take care of ourselves first and understand every aspect of it. Get mental health, get whatever you need to get for that. Become an expert in motivational interviewing or the art of listening and reframing, whatever it may be for you, right? Increase your knowledge in the science of pain. Become a painiac. We call ourselves painiacs, as in pain maniacs, I'm a maniac. I typically like that music played, but bring humanity, humility. This whole journey has brought so much humility to me that I know nothing. We know nothing. It's like we're going into space and we know nothing. Even the astronauts know nothing about space. That's where we are. We're kind of going into that space. We know nothing. The only person who knows is the patient. And that's what we got to listen to as them. So I'm going to have you stand up. And I want you to hold each other's hand. So I call the union of dedicated participants to rise and hold your neighbor's hand. We have a job to do. Our communities need us. We need each other. Our kids need us. We are enough. We cannot do this alone. Our language needs to have safety embedded in us. My pain story was transformative for me as a patient and as a clinician. It empowered me. Mind your language as your words are changing people's lives. Pain needs to be understood in its holistic nature to address the real problem. Let's respect the person we are talking to as we're all fighting our own battles. Fear shows up in our beliefs, in our thoughts, and in our emotions. We can change. Sorry, I moved. We can change our patient's life around pain by just listening, by letting them know that their pain is real and that we believe them. Bringing hope that pain can change. Provider language needs to be more empowering, because the time is always right to do what is right. And you're here to do what is right.